we're going to go ahead and get started. We would like to welcome you to our talk about bridging clinical psychology and behavior analysts in rural communities to advance social development in adolescents with autism. So a quick overview of the workshop. First, we're going to go ahead and meet Jessica and I, which are the presenters. Then we're going to go over the need for behavioral health support in rural areas and how these rural areas are kind of like a desert for these behavioral health supports. We're also going to talk about how we have used interprofessional collaboration in order to develop a social skills group for teenagers with autism that we call Club 618, and how we use different preference assessments and conducted some research with preference assessments with our Club 618 group. And then we're going to go over a few of the implications and future directions that we are hoping to do with our research and with the social skills group. So to get started, my name is Lynn Schumacher. I earned my master's degree from Mount St. Mary's University in applied behavior analysis, and I received my BCBA in 2023. I am currently a second-year PhD student at Southern Illinois University in the Behavior Analyst and Therapy program under Dr. Leslie Schumacher. And my current research interests include preference assessments, generalization procedures, and work with adolescents with autism.
All right, hi everyone. My name is Jessica Hinojosa. No, you're good. I got my master's in psychology with an emphasis in health psychology at the University of Wisconsin in Milwaukee. And I'm currently a fifth-year PhD candidate at Southern Illinois University. And I'm in their clinical child psychology program, also under the direction of Dr. Leslie Schumacher. And my clinical and research interests are generally in the area of pediatric psychology and working with interdisciplinary teams, behavioral sleep medicine, as well as neurodevelopmental disorders.
So Jessica and I both attend Southern Illinois University in Carbondale, and part of our schooling is we work at the Center for Autism Spectrum Disorders. This is a center that is provided nonprofit through the TAP funding, through the organization of TAP. And it is a center that provides individuals in the Southern Illinois region with high quality services for individuals with autism spectrum disorder and their families. And what we do is we offer interprofessional training, and it's also a research center. So it focuses on community services, student training, and research. And we provide both speech and applied behavior analysis services. These services are provided by our graduate student clinicians, and these students are overseen by respected licensed professionals in their fields.
And so overall, there is a really high need for behavioral health support in rural communities. And according to the CDC, approximately 61% of regions with a shortage of behavioral health providers are rural. And within those rural communities, about 18.6% of rural children often have a diagnosis of a mental, behavioral, or developmental disorder. And narrowing in on teens in rural communities, they're even more likely to face challenges accessing social support systems, a lot of times due to fewer socioeconomic resources, regional difficulties, things like that. And when we narrow in further on rural Southern Illinois, the access to behavioral health services for teens with autism is especially scarce. And we did not know of any social skills training available. It's pretty much non-existent. And so there's limited clinics, there's limited providers, limited school staffing, and that creates limitations in access and development of social skills training programs. And the caregivers that we have worked with, they've expressed that they have pursued homeschooling for their child just because of all the bullying that's happening in the systems. And even in homeschooling, when they attend co-ops and things like that, there's still a lot of social bullying, teasing. It's difficult for our teens to connect. And just broader, this is just a map of the Illinois state, and this is just a public health community map that reflects the number of people who are serviced by one mental health provider in a given county, not necessarily children, but just overall. And we are in Jackson County, and so approximately 225 people is to one mental health, behavioral health provider. And so over Illinois, the mental health professional shortage areas are indicated in the dark blue region, which our county is included in there, and those are representative of rural communities.
So we would like to open it up for a quick discussion. So we would like to ask you guys, do you currently collaborate with other professionals? And if so, what does that collaboration look like? And is there any guidelines or like evidence-based practices that you follow when it comes to collaborating with these professionals? You can take a moment, discuss it with each other, and then if you want to, you can go ahead and share it with us. Alrighty. First, I'd like to thank everybody for their active participation in this. I loved hearing you guys chatting. Would anybody like to share if they currently collaborate with other professionals? Definitely. Is there any like guidelines that you follow in order to get to that cohesiveness? Thank you so much for sharing that. Would anybody else like to share? Yeah, it's definitely having those effective relationships. And I'm going to hand the mic over to Jessica, and she's going to talk about some different ways that we can get to those cohesive collaboratory relationships.
Yeah, and it's great to hear that some people are already very integrated in different professions. And so there's a lot of different models of care that we can approach this from. And so the broader umbrella term we typically use is interprofessional collaboration. And so that is going to describe all models of professional collaboration, but generally is going to refer to it in involving two or more professionals in the treatment or assessment of a shared client or a shared patient. And so then that can be broken down into multidisciplinary teams, interdisciplinary teams, and transdisciplinary teams. And so the multidisciplinary team is referred to as like a salad, where providers are working within the scope of their own discipline, and they're delivering treatment according to their specific practice. And they may be addressing different concerns or different targets in treatment, but they share the same patient or the same client. So it's where it's like a salad where you have all these different pieces. They're separate, but they're shared in the bowl together. The interdisciplinary team is more integrated, and it involves combining or coordinating the practices of each discipline. So we see a little bit more collaboration there, and the difference is that now we have shared goals, mutual goals that we are working with that patient on. And so an analogy to that would be like a soup. You have a lot of different ingredients in there still. Some of them are marrying to each other as they're cooking, but still serving the same purpose of creating that one bowl. And then we have the transdisciplinary team, which is a true integration of the discipline-specific domains. So individuals may have to go a little bit beyond their scope of practice. And there's mutual appreciation for one another's profession, and you're sharing specialized knowledge and expertise in treating, assessing that patient or client. And so there's a nice little image to summarize that from the paper. And in there, they emphasize specifically the importance of transdisciplinary collaborations for individuals who have autism. And this is really important to comment on because a lot of individuals with autism have a lot of comorbidities. They may have chronic health conditions. They may have language concerns they need help with. There's mental health related concerns. And so it's really important that we have that true integration from all of those professionals to create effective treatment planning, and they're all on the same page with that. And so Bowman et al. Is a nice paper that proposed some standards for effective collaboration in a treatment team. And I'm not going to go into all the specific details of those, but there's 8 standards that they proposed. And so the main tenets of that is emphasizing collaborative communication across the professions. There's the acknowledgement that there's distinguished roles in the collaboration, organization of treatment, and again, distinguished roles. And there's standards related to client care, conflict resolution. Every profession has their own perspective, so it's important to have that in there. How to facilitate joint partnerships, being on the same page with evidence-based practice, and then facilitating a collaborative culture across professions, across the team, with the families that we work with.
So taking these 8 steps that Bowman et al. Laid out, Jessica and I looked at the field of applied behavior analysis and the field of clinical psychology, and first we started by defining each of them. So the field of applied behavior analysis is a field in which the focus is on solving problems of social importance, and it uses principles and procedures of behavior analysis. Behavior is the subject matter compared to mental structures and phenomenon. So what that means is behavior is considered anything that the individual does when interacting with the physical environment. There is a continuity between publicly observable behavior and private events such as thinking and feeling. And what this means is that private events are no different than public events in that they are controlled by the environmental events, and the causation comes from the environment. The individual behavior is what is predicted and controlled compared to the behavior of the group or populations of the individuals. The cause of behavior or the explanation of behavior comes from the environment, and applied behavior analysis is considered a natural science in that there is research that is conducted in order for theories to be developed. And what is important here is that the same principles that are applied to the individuals that we're employed to work with are also employed to our practitioners and our researchers. And so the largest population that ABA is employed to work with is autism.
And so then when we look at clinical psychology, there is a lot of different directions that clinical psych can go into, but I'm going to focus on the clinical child aspects of psychology. And so in that profession, we're focused on the assessment, the treatment, and prevention of social, emotional, behavioral, and developmental disorders in children and adolescents. And this profession includes training students, informed by evidence-based theories and research. And a huge part of it is willingness and openness to consultation and collaboration with other healthcare providers. And then there's a lot of different evidence-based interventions, but a lot of them are typically going to be rooted in cognitive behavioral therapy, where we're looking at the complex bidirectional relationships between feelings and thoughts and behaviors in the context of a psychological and behavioral health concern.
So with these two definitions of the fields in mind, we looked at what do they have in that are the same. So we knew that ABA used reinforcement procedures and behavior shaping. We also know that ABA used discrete child teaching and behavioral skills training. And they did data-informed treatment decisions. Where, on the other hand, cognitive behavioral therapy had behavioral experiments and exposures, cognitive restructuring and flexibility, emotional feeling and identification, and motivational interviewing and Socratic questioning. So together we said, well, what is the same about them? And what's the same is that we're both employed to change behavior. We focus on behavior change that's socially significant. And to do this, we set goals. And in order to reach these goals, we do skills training. Although these skills training looks different across the different disciplines, we had many things that were the same, such as we were employed across the ages and populations. Not one of our disciplines was specifically for one age or one population. We also had measurable progress that we collected throughout the skill training and goal setting. And the biggest of it all is that we used evidence-based practice across both of the discipline. Although those evidence is different, we can combine them and create something beautiful, which we did.
Mm-hmm. And what that creation was our Club 618 Social Skills Training Program. And this group was developed in 2024, and it was for adolescents with autism between the ages of 12 and 18 years old. Individuals were ineligible if they had a cognitive development that was below the 6th grade level, if they exhibited extremely aggressive behaviors, and they were determined to be nonverbal. And so our professions that were involved in this, our facilitators, co-facilitators were in clinical psychology, behavior analysis, and we also had speech-language pathologists involved in the group. And so we had 2 bi-weekly 75-minute groups with about 5 to 6 adolescents per group. And at the same time, we had a simultaneous parent-led group, and it was more of like a support group for them, and we would check in with them. We were able to hold about 8 to 10 sessions per semester. And the foundation of the programming we developed was based on the Peers Treatment Manual, which is a common social skills training program, and it's been adapted to work with developmental and autism spectrum disorders. And so when we screened each of the families for the group, we did ask them what skills they wanted to prioritize. And there's a lot of modules in the Peers program, so we wanted to have a sense of like, what modules do we need to prioritize? And that included trading and exchanging information with peers, maintaining two-way conversations, electronic communication, how to choose friends, how to identify humor, entering and leaving conversations, good sportsmanship, and also how to handle teasing, bullying, and disagreements that are occurring in the social context. And so in addition to those modules, families also had a lot of concerns related to daily living skills, flexible thinking, thought challenging, their ability to read nonverbal cues, emotion identification, and then also they needed a lot more support navigating the school system in the Southern Illinois region.
Click the wrong button. My bad.
You're good. And so each semester, each skill that we taught, it built upon one another each week. So the sequence each semester, it made sense, so that way we could still reinforce each of them. And then when we are learning and teaching those skills, the adolescents can earn points for their engagement, their participation, for engaging in the effective social behaviors. And so they're given opportunities to exchange those points for preferred items or prizes at our end of semester party that we have for them. And during the group, they're provided opportunities to apply the skills in the group context with our support. And then we schedule outings in the community that allow them to practice those skills in a naturalistic setting. And that's included our bowling alley on the SIU campus, attending other sporting related events, and we had an outing at the public library where they did a scavenger hunt to practice their skills. And when we're teaching the skills, they are acquiring those skills through a behavioral skills training model, which Lynn will talk a little bit more about.
So when Jessica came to me and we were talking about developing the social skills program, she was telling me how the peers manual sets up training. And I said, well, hey, that sounds a lot like what we use in ABA, and we call that behavioral skills training. And behavioral skills training isn't just something that we use with the population that we work with. We also use it a lot when we're training our clinicians and BCBAs, RBTs, in order for them to provide the interventions. So there are 5 components to behavioral skills training, and the first one is instructions. So you're gonna describe the skill and provide a rationale for that skill. In our social skills group, what we did was we did a didactic and a discussion portion of the 75-minute meetings that we had. Following instructions, there's going to be modeling. This is when your clinician or the instructor is going to demonstrate the skill that was previously described. Again, for our Club 618, we had it between clinician role plays happening. So Jessica and I would role play it, or with the help of our speech clinicians, they would also help us role play and model it for the individuals. We would then have a conversation about it and ask the individuals, what do you think went well? What do you think didn't go well? Following that conversation, we then went into rehearsal. So this is where the individuals that we're teaching actually practice that skill that is described, and that's when they modify that skill. That's when feedback is provided. It's happening in front of the instructor. And what we did was we broke our students up into small groups, and depending on the skill, they might have been paired with another peer in the group, or they might have been paired with a clinician, like for the electronic communication, we paired them with the clinician because we didn't expect anybody to have to give their phone numbers out. And while they were doing that rehearsal, our clinicians walked around and provided that in-the-moment feedback. And that's based on their individual responses. So that feedback is individualized. They're receiving reinforcement, corrective feedback during this time. And then following the feedback procedure, later in the semester, they get a chance to go out and practice this in the real world. And that's where our bowling alley adventure comes in, going to the library and going to other sporting events. So a lot of the times our clinicians will, even if it's not part of the social skills group, they'll join us just so that they can continue to provide that feedback and positive reinforcement to the individuals, even if it's when we see them again in social skills group saying like, hey, you did a really great job, communicating your wants and needs at the basketball game and asking to go to the quiet room, something like that. So we're gonna provide a quick demonstration, real quick, of what our behavioral skills looked like when we were teaching it to the individuals. So what we're going to teach is providing compliments to others. So what I'll do is I'll provide the rationale to Jessica. that providing compliments helps you make friends because it can evoke a conversation about mutual interest. After I provide that rationale, I would provide her with the instructions. So first, Jessica, if you're in an environment and you see a peer or someone in your environment that has an item that you like, you can provide a compliment. First, you would want to approach the individual and get their attention. Second, you would want to provide the compliment and wait for their response. So, an example of this is, hi Jessica, I really like your autism pin on your shirt.
Oh, thank you.
All right, would you like to practice it?
Sure. Hi. I really like your shirt today.
Jessica, I loved how you waited for the response from our audience member before you provided that compliment, and you also allowed for them to respond. You didn't just turn and walk away after you provided what you had to say. So obviously, that was really brief. We break it up into 45 minutes. There's different rules that they follow and different segments of the teaching, but that's pretty much what it looks like. And so during that, that's when they're earning those points. While they're engaged in this behavioral skills training during the meetings, they're earning points. And so we utilize two different forms of reinforcement contingencies throughout our social skills group. The first one we used was independent group contingencies. In an independent group contingency, a group member who meets the criterion receives the reward, and individuals in that group are independent of each other. So for example, if the criterion was 20 points, and I earned 19 points, and Jessica earned 21 points, Jessica's gonna receive that ice cream party at the end of the year where I'm not, and that's not going to affect that Jessica gets it. So if I don't make my points, it's not gonna affect Jessica at all. So that's the model that we used with earning points in the social skills group. So points were earned during the session that could be exchanged at the end of the session for prizes. In addition to that, we had non-contingent access to reinforcement, which we use fidget-like items. So in the tables of the meeting rooms they came in, they had just fidgets laid out on the table. And they weren't contingent on any other response other than that they were being safe with them. So if they started being unsafe with the fidgets, we had to remove them. But other than that, they just had free access to them. But while we were in the meetings, we were questioning, did they actually like these fidgets, or were we just picking what we had around the clinic? And were the fidgets doing what we hoped to do? Were they actually increasing in-seat behavior? So that leads me to my second discussion question for you guys. So when you're working with individuals, do you use reinforcement, whether it's kids, teenagers, and adults? And if so, how do you determine what that reinforcement looks like when you're working with the individual? Would anybody like to share? Okay, so you use kind of what we would call like a reinforcer assessment to see is the behavior actually increasing when that item's present. But how do you figure out what item to use? So I'm just going to summarize what he shared. He shared that he will do interviews with caregivers at intake and then throughout their sessions with clients if it's available, or he'll do some form of selection-based preference assessment called an MSWO. Would anybody else like to share? Yeah, so she just shared that she knows what to use because she knows her clients. She takes the time to get to know them, just as we heard in that previous talk. Get to know them. That's going to be huge for your treatment of the kiddos. So in the field of applied behavior analysts, we use what is called a stimulus preference assessment. And what that does is it determines an individual's hierarchy of preferred items. And these items have the potential to increase desired behavior, but that's only if these items become reinforcing. So the example I like to think about is with me and Jessica. Jessica loves coffee, and I like coffee. But I love, like, just fresh tuna. So if you told Jessica to go run 7 laps around this building for coffee, Jessica's gonna run those 7 laps. But if you told me to go run those 7 laps for coffee, just because I like it, I'm not gonna go do that. But if you told me you got some fresh tuna on the other side of those 7 laps, I'm running those 7 laps as quick as I can. So that just goes to show that not just because you like something doesn't mean it's going to increase your behavior. It doesn't mean that you want to work for it. So the results of these stimulus preference assessments produce a hierarchy of preferred items. And in order to determine if these preferred items are actually reinforcers, you have to assess the effect of those reinforcers. So there's several different methods of stimulus preference assessments that are currently out there and that are evidence-based. One of them being the multiple stimulus without replacement, another being the paired stimulus preference assessment, along with a free operant preference assessment and a single stimulus preference assessment. Today in this talk, we're gonna focus on the multiple stimulus without replacement and the paired stimulus preference assessment. So there's also been research done by Lynn and colleagues that there are several different modalities that the stimuli that you present in these preference assessments can be. There's been evidence that both pictures and videos are effective at assessing for a preferred hierarchy. There's also been evidence that just using the tangible items or verbal rapport is also effective. So this is an example of what a paired stimulus preference assessment would look like. As you see, each of the items is paired with the other item at least once and on each side of the individual's perspective. And if we look here, it is the percentage of selection across the number of times that that item was presented that gives you that hierarchy. So this individual really liked to go on vacation, followed by coffee and TV they might not even have said was reinforcing. So their hierarchy would be vacation, coffee, TV. And one of the downsides of the paired stimulus preference assessment is that the more stimuli that you add to the preference assessment, the longer it's going to take because you have to pair each of them with each individual one. So then there's the multiple stimulus without replacement. In this preference assessment, there is a line of stimuli that's presented to the individual, and then they're prompted to make a selection response, and that item that they picked is taken out of that array or that lineup of items, and the remaining items are presented. So we see here that the individual's first choice was vacation. When they made that selection, the clinician represented the next 4 items: TV, money, coffee, and food. And they removed the previous selection. And that continues until either all items are selected or the individual indicates that they no longer have a preferred item. One of the benefits with the multiple stimulus without replacement is you can add a bunch of items and it not be as long as the paired stimulus is because the number of trials is only as many items as you have introduced. So if you're doing 10 items, theoretically, it's going to be at most 10 trials because they're making a selection each time and you're removing that item. So they no longer have that response option. So you're minimizing their response options. So an example of what this would look like for the array of stimuli in the MSWO would be up here. So you would just line them out in a row of whatever the stimuli were. So the stimulus preference assessment gives you a hierarchy of preferred items, but as we've talked about, not all preferred items are reinforcing. So how do you determine if they're reinforcing? You conduct a reinforcer assessment. So it is used to determine which of the identified preferred items will increase responding or act as a reinforcer. And in this, 2 or more items are associated with the different response options, and the response allocation is then compared. And the stimulus that is correlated with the highest response allocation are the items that are considered reinforcing for the individual. So there's several different types of reinforcer assessments, one of them being a 2-response option reinforcer assessment, which we call that a concurrent operant reinforcer assessment. There's also an increased response requirement, which is called a progressive ratio reinforcer assessment, in which they can go for 2 questions, then 4, then 8, and you see where what they say is kind of like the breaking point is, where is it no longer reinforcing for them, or where is the response effort too high for that item, and you would have to reassess for the preference. And then another one is an in-the-moment assessment. So how does this relate to Club 618? So as we said, we gave them non-contingent access to fidget items that were just there, because we know how if you're being just lectured at for a little while, you need something to do with your hands. So busy hands keeps people out of trouble. So we provided those fidget toys so that they could stay engaged with something while we were presenting. But we didn't know if there was actually a preference for this, because we didn't conduct any formal preference assessments. We just used what we had around the clinic, what we knew were preferred for other individuals. So when we thought about running a formal preference assessment, we saw that with our individuals, we might just be able to ask them what they want instead of having to do a preference assessment with the actual items in front of them. But we were unsure if that verbal preference assessment and that tangible preference assessment would provide the same or similar hierarchies that we're even reinforcing. So that's when we began to look at the literature. And we looked at 2 different things when we started looking at the literature. We wanted to know what was the research around the current population, which was our adolescents and teenagers, and the use of preference assessments. And then we also wanted to see, what did the research say about comparing the verbal and the tangible hierarchies? And that led us to the research that we're about to discuss. So what we did was we conducted a comparison of verbal and tangible preference assessments at the Center for Autism Spectrum Disorder, mainly with our vocal verbal clients, to determine preference for the individual hierarchies and to see if these hierarchies actually produced reinforcer efficacy. So what does the current research say? So the current research on stimulus preference assessments with children with disabilities says that the verbal and tangible paired stimulus provided similar hierarchies. So when verbal and tangible paired stimulus preference assessments were compared, they had similar hierarchies. Another article said that when the paired stimulus, in the paired stimulus preference assessment, when the stimuli is present versus when it is absent, produces different hierarchies. So when they're doing a verbal paired stimulus preference assessment and they can see the item compared to not being able to see the item, the hierarchies change. And we also saw that in the forced choice comparison of verbal and tangible preference assessments, the results showed identical hierarchies of preferred items. So that was with kids, but we were working with teenagers, so we wanted to expand our search to what did the research say about stimulus preference assessment comparisons with adults with disabilities. So some of the research showed us that verbal, picture, and tangible paired stimulus preference assessment did not have resulting hierarchies that were similar, while others showed us that it was based on the individual's skill level and discrimination prior to that, the comparison being conducted. And we also saw that when it was conducted with individuals outside of the field of autism, the results showed that 75% of participants had identical hierarchies. So what does this mean? we saw that many studies compared verbal and tangible paired stimulus preference assessments, but not many of them used multiple stimulus without replacement, if any at all. We also saw that it was done with both children and adults, and many of the age gaps that we saw were happening were at the adolescent age and the teenager age. So not many of these articles showed how they were assessing preference for individuals who were 12 and older. And we also saw that higher skill levels of discrimination promoted higher correspondence between those verbal and tangible preference assessments. We saw that there was limited study on the preference assessments with teenagers and adolescents, and even less studies that assessed the social validity or the individual's preference towards the procedures that were being used to assess for their preference of items. So the purpose of this current research is trifold. We started with comparing verbal versus tangible MSWO arrangements and to see if they produce similar hierarchies. Following that, we conducted a social validity interview with the participants to determine what their disposition towards the different assessments that we used with them were. And then we also wanted to determine if there was reinforcer efficacy of the hierarchies identified across the verbal and the tangible preference assessments. So to do this, we recruited 8 different participants and we conducted this study within classroom settings in our clinics. So the 8 participants came from both of our social skills group and our language and learning group at the Center for Autism Spectrum Disorder. And we had a mean age of 12.13 years old with a range of 7 years old to 16 years old. So you may ask, why did we include these younger kiddos when we were focusing on teenagers? That's because they fit our inclusion criteria. Our inclusion criteria stated that our individuals had to engage in consistent vocal-verbal responding, they had the ability to make a selection from an array of items, and were between the ages of 4 and 17 with a diagnosis of autism. So 2 out of our 8 individuals were from our language and learning group, and 6 of them were from our social skills group. And only 4 of these individuals completed the reinforcer, completed the concurrent operant reinforcer assessment. So the independent variables that we used for the preference assessment was the modality of the preference assessment presented, either the verbal or the tangible preference assessment. And the dependent variable of that was the percentage of the percentage of selection across the different stimuli modalities. For following the preference assessment, we conducted a color preference assessment, and that was used in order to determine the signals that were used in the concurrent operant. What we didn't want was, we knew going into it that 2 of our kiddos had a high preference for the color red. What we didn't want was them to just sit in the chair because it was the red chair, even if they didn't want the item that was there, or didn't prefer the item, or it wasn't reinforcing. So we wanted to mitigate those color biases that we might see. And so the dependent variable of that was the selection of order of colors. So the independent variable for the concurrent operant reinforcer assessment was the concurrent response options associated with the preferred items, and the dependent variable was the percentage of time allocation to different response choices. So now we're going to go into the procedures that we used during this research. So like I've been saying, we did a verbal versus a tangible preference assessment comparison. So in the verbal preference assessment, we used 3 separate trials, and the results of those trials were aggregated to determine the preferred hierarchy. Individuals sampled each stimuli prior to the assessment, and in the verbal preference assessment, individuals were read or shown a list of items. The stimuli were not visible to the individuals, and they were asked, which would you pick? A verbal selection response resulted in 15-second access to the item. Now, in comparison to our tangible preference assessment, everything remained the same, where that we used 3 separate trial blocks, aggregated the totals to determine the average hierarchy of preferred items. They sampled the items prior to the presentation of the preference assessment, but it changed because the individuals were presented with an array of 4 items that were visible and asked to pick the one they want. Their physical selection response resulted in 15-second access to the items. So this is an example of what our preference assessments look like. So on the far side, we see that a verbal preference assessment, depending on the individual, sometimes they ask to see like the words. So we would show them the verbal text and allow them to make that selection based off that, but they still were not able to see the item. So we're gonna provide you a quick demonstration of what this would look like. So for time's sake, we're just going to say that Jessica has already sampled all of our stimuli up here, and she knows what each of them are, has played with them. And now I am going to conduct a verbal preference assessment with her. So we're going to call this a fidget button, a squish ball, a noodle, and a fidget cube. So I'm going to take the items and make sure they're not visible to Jessica. When I was conducting this with our clients, I had them in a bag, and I was pulling out of the bag. So I'd ask Jessica, which one would you like out of the list?
The noodle.
So then she'd play with the noodle for 15 seconds. I'd say, all right, it's my turn. And then I would put the noodle in another area where the individual would then know that it is no longer a response option. And then I would go back and hide the item again and represent that and continue until either the individual has indicated that they wouldn't like it or they have made a selection of all of them and I have a hierarchy. So following that, we then would conduct a tangible preference assessment in which I would lay out all of the items on a table in array, and I would say to Jessica, pick one. I would remove the items so that she couldn't just access any items she wanted freely and let her have 15 seconds with that item. I would then say, it's my turn, take it back, and then since it's a multiple stimulus without replacement, we're removing the item she selected, and now she only has 3 items to select from. And I would prompt her, pick one. Remove them, and let her keep playing with it. So I'm sure you guys have all ran preference assessments, seen them run, so we're gonna call it that with the demonstration on that. So the stimuli that we used during the preference assessments were individualized across the participants. So these are the examples of the items that we used. Yeah. It was a good time playing with these toys with the kids, except for the ocean-themed slime. It kept spilling everywhere. So following the preference assessment procedures, we conducted a social validity assessment, which we conducted it in an interview format, and there were 9 questions. And what it looked like was the researcher would sit in a classroom with the participant and read these questions to the participant. It assessed the participant's general disposition towards the different preference assessments that were used. And so this is just an example of what the social validity assessment looked like. So along with the researchers reading the script to them, they also had these icons that aligned with the answers so that they had a visual representation of how they were answering. So in the social validity assessment, it included questions pertaining to the individual's preference towards different preference assessments used, difficulties arising from the use of verbal preference assessments, and preferred method and willingness to engage in similar procedures. So potential implications of the social validity assessment was that you could determine adolescents' attitudes towards the procedures used, and once you determine what their preferred method is, you can then utilize it when you're working with these individuals so that you're taking their point of view into your intervention. So following the social validity assessment, we conducted the color preference assessment. The purpose of the color preference assessment was used to find neutral colors to be used during the concurrent operant reinforcer assessment. And we had 9 colors that were presented using a multiple stimulus without replacement design, and participants were prompted to pick their favorite color. The color that was selected was removed, and the preference assessment continued until the individual either selected all of the colors or they indicated that they have no preference towards those colors and they wouldn't pick them. The items that were lower in the preferred hierarchy or items that were not selected were considered neutral items and were used during the concurrent operant. So in the concurrent operant reinforcer assessment, it was used to determine if there is a reinforcer effect for the items identified during the preference assessments. The individuals were provided with 2 or more response options that were each paired with a consequence. Higher response allocation to one choice in the arrangement indicated that that item increased behavior more comparatively. In this procedure, the individual was prompted to pick a seat, and the duration of response allocation for each response option was recorded. So this is what the room looked like. As you see, there's a piece of paper on the ground underneath each of the seat that was aligned with their different neutral colors, and each of them was assigned an item. So if you see sitting on the seat, we got like a cheese cube and a water maze sitting there that was assigned to the yellow and the orange. So concurrently, over in the corner at that table, our researchers would sit, and they had the Timer Plus app. And what they did was they recorded the total duration of the session, which was 1 minute and 30, and they were able to start a timer for each of the individual colors and stop it when the individual got up and moved to another one so that we could take time on each of the individual response options. So right now we're gonna go ahead and show you 3 short videos of what these procedures actually look like. So in the training, we have the kid come in, we ask them to label the color and to tag the item that is present. So this is what it would look like. He is tagging cheese, he's saying yellow. He didn't know what that was, so I had to tell him it was a water maze. And then he said white, and I say, when you sit in white, you don't get anything, because that is our control condition. So following that, this is what the first trial would look like. We come in and we have the individual tag the colors that are present in the room, and then we prompt them to pick a seat. The individual will then pick a seat, and they have the option to move throughout the session after they pick that seat. They will be provided with 1 verbal prompt during that 1.5 minutes of, you can always pick another seat if you want. And following the first trial, we then stop having them tag the colors when they come in, and they just go in and we say, pick a seat. He doesn't change seats in these videos, so there's nothing really that interesting with them, but it was just a quick demonstration of what our procedures would look like when we were working with our individuals. All right, so now let's go into some of the results that we found. So we see here on our x-axis, we have the different stimuli used across the participants. So like I said, they were individualized for each of the participants. And on our y-axis, we have the average hierarchy order across the 3 trials. Our orange bars are our verbal, and our blue bars are our tangible preference assessments. So as we see, there's not much difference across the 2 preference assessments. We don't see very much change in the hierarchies that were produced across all 8 of our participants. What we might see is a change from number 1 to number 2, number 2 to number 3, or number 3 to number 4. But there was no blaring like 1 to 4 switch in preference. But statistically speaking,
Yeah, so we also wanted to just see exactly like how much numerical difference there was between the 2 modalities. So in the table, we have change scores that were computed by taking the difference between the average item ranking across the 3 trials, where the verbal average was subtracted from the tangible average. So in the table, any positive change scores indicated that the tangible modality yielded slightly higher rankings than the verbal modality. And those are highlighted in the green. Those that yielded a negative change score showed that the verbal modality yielded higher rankings than the tangible modality. So those are in the bright purpley pink. And then for a majority of the table, as we saw in the graphs as well, there wasn't that any difference between the verbal or the tangible modality and did not impact their item rankings.
So based on the results of the graph and the change scores, we saw that there was minimal difference seen between the hierarchies produced by the different modalities. And that provides us with the implication that either method is effective for identifying hierarchies of preferred items. But then what did the results of the social validity tell us? So it told us that individuals like to see the items and play with the items. They did like to talk about it, but they also found it hard to imagine the stimuli when they weren't present. And a lot of them did say that there was a change in their choice after seeing the stimuli. When asked what their preferred method was, 7 out of 8 of them said that they preferred the tangible method compared to the verbal method. And when asked if they would do this activity with other stimuli or other people, a majority of them said yes. When asked if there was other ways to show a preference, they said, as most teenagers probably would, photos on your phone, and then also videos. And 38% of them said that the ways that we provided were good enough for them to tell us how they liked or what they liked. So then the results of the color preference assessment and concurrent operant reinforcer assessment. So as I said, the results of the color preference assessment inform the signals used for the different items in the concurrent operant reinforcer assessment. And the stimuli used in the reinforcer assessment were identified through the preference assessments. And the purpose of the reinforcer assessment was to determine the reinforcer efficacy of the items that were identified as preferred, because like we said, not all preferred items are actually reinforcing. So here we have the preference assessment graphs that I already showed, and on the far side we have the color preference assessment. And we see that it's just a hierarchy of preferred items, number 1 being the preferred color going down to the least preferred. So for participant 4, with these graphs, we see that on our x-axis, we have our trial blocks, and on our y-axis, we have percentage of 90% engaged in stimuli. The individual colors across the preference assessment align with the colors that were actually used in the concurrent operant reinforcer assessment. So the results of this participant actually prompted us to make a few changes in the concurrent operant. So we started with having the individuals standing, and they could kind of wander around the room, pick whatever square they wanted to stand in. But we thought this isn't really indicative of what we're hoping that these fidget toys do, which is we're hoping that it keeps them seated and not wandering around the room while we're doing didactic teaching. So we added chairs. So now they were, and that's what you guys saw in the videos, was that there were chairs present. But the results of this participant did show us that the purple, which is neutral, when the stimuli were present and no stimuli was associated with the purple, we saw response allocation to that purple decrease, where when no stimuli were correlated with any of the responses, we saw that purple went back to being a response option and response allocation went there. So for our next participant, participant 1, we saw that his preferred stimuli were the maze and poppet, and the colors that we were going to use were light blue, green, and purple. This participant actually just gave us the rainbow order, and I knew that his favorite color was red from working with him, so I just made sure not to use red with this client. And the results of participant 1's concurrent operant showed us that the maze was the item that increased responding, and that corresponded with the verbal preference assessment. For participant 2, we saw that the maze and the cheese cube were their preferred items, and that the colors we used were yellow, purple, and pink. We saw that the cheese cube was the item that increased responding the most, and the results aligned with the verbal preference assessment. So the results of participant 3, we used the cheese cube and the lizard, And the colors used were light blue, purple, and pink. And we saw that the reinforcing item, again, was the lizard. And again, it corresponded with the verbal preference assessment. So for participant 7, we saw that the poppet and the cheese cube were the number 1 and number 2 preferred items. The colors used were tan, green, and orange as the signals. And based on the results of their preference, or their concurrent operant, we saw that the cheese cube was the reinforcing item, which, as we see, this individual cheese cube was just number 1 across the board for verbal and tangible, so the results of the concurrent operant aligned with both the verbal and the tangible preference assessment. So some of our preliminary findings are that both the verbal and the tangible preference assessment produce similar hierarchies. The results of the social validity indicated that participants preferred the tangible preference assessment when compared to the verbal, and that the results of the concurrent operant suggest that preferred items identified as number 1 and 2 did have reinforcer effect. And we found that a majority of the results of the concurrent operant corresponded with the verbal preference assessment, indicating that verbal preference assessments identify hierarchies that are reinforcing. So some preliminary implications. The results of the preference assessment suggest that both verbal and tangible modalities provide similar hierarchies of preferred items, indicating that either would be an effective means of identifying preferred items. We also saw that the results of the social validity suggested that although both formats had similar hierarchies, individuals actually preferred to see and play with those items. So it's important to consider what the individual preferences are, because we did see that 1 out of the 7 wanted the verbal. So it would be important for that one to use verbal compared to the tangible. And the results of the concurrent operant shows that the items identified as preferred have reinforcer efficacy. Although there's minimal difference between the modalities of preference assessments, results of the concurrent assessment align with the verbal modality of preference assessment. And this is some translational research because we did it with in a very controlled environment, and we would like to see if it actually increases responding in a group setting. So some more implications are that since both of them are effective and produce minimally different hierarchies, when you're in a time crunch, you can use the verbal preference assessment for those who have vocal repertoires. And no matter the age, individuals have differences in preference on how they like to indicate their preferences. So it's important to always take that into account when you are formulating your preference assessments. And the results of the reinforcer assessment show that fidget-like items increase responding, but further research is needed to provide the implication that they have the potential to increase responding during group settings. So some preliminary limitations are that we had some major time blocks that occurred just due to the setting of the semesters, participant retention, and many other things. Like I talked about after the first participant, we adjusted the procedures for the concurrent operant. And there were limited stimuli used in the preference assessment due to wanting to have stimuli that resembled the ones that were available in the clinic. So how does this tie back to our Club 618? So when you're working in a group therapy setting with individuals with autism, there's a need to systematically assess for preference during these group therapies. Both the vocal and the tangible preference assessment can be effective for individuals in group therapy, but the individuals indicated a preference for seeing and engaging with the items before making the choice. And the fidget-like items identified as preferred may be utilized for increasing socially significant behavior. So future research should look at using other modalities to compare verbal and tangible preference assessments, as well as this research was only conducted with teenagers and children. Future research might look at assessing this format of research, especially the social validity assessment with the adult population, and use a concurrent operant format to test for actual preference of the preference assessment procedures, and conduct a natural environment reinforcement assessment to determine if fidget-like toys increase attending-based responding in group settings.
And then tying it back to how we all work together, we've done a lot of reflection and getting feedback from families, from clinicians, and trying to figure out how to best evolve this group into something that is effective and meeting the needs of our families in the rural community. And so we, in integrating our disciplines together, we took a transdisciplinary approach, and we continuously reflect on and discuss how we delegate the implementation of the social skills intervention procedures that we're doing, according to the scopes of our practice, but also respecting and learning about what that looks like from each of our standpoints in practice. And we also want to acknowledge that transdisciplinary care is not simply a hodgepodge of, I'm just going to put all these different pieces together and call it an intervention, but rather we're using our frame of practice to create a holistic treatment approach for the populations that we serve, and we're using evidence-based practices to do so. And then it's hoped that we can continue to increase access to interprofessional trainings for healthcare providers and professionals. And the training is necessary to effectively implement a transdisciplinary model of care when working with families of youth with autism, and especially in our rural communities. And we had several partners that helped us keep this group going every semester. The SIU Center for Autism Spectrum Disorders is funded by TAP, and our group itself was funded by 100 Women Who Care, Jackson County, the Marlin Fishing Team, Taste Bud Snacks, and Murfreesboro Knights of Columbus. We couldn't do it without them.
And this is our references.
Yep.
It looks like we have just a couple minutes. Does anybody have any questions? Yes. So we read a study that it was that study plus what they had talked about in the introduction of that study that led us to say, well, hey, is this actually something that is useful? Because one study says yes with kids with ADHD, another study says no with kids with autism, but we also wanted to look at how young were they working with? They were working with younger kids. So now that we're working with teenagers who have this vast history of being in classrooms and being in learning settings, is it just like they need something to do with their hand, or they're going to be tapping and making noise that's distracting everybody else? Or if you can pull something in your hand, is that going to prevent you from, having to pace back and forth? Obviously, we weren't going to say, like, you can't pace, but we were just trying to see if we can decrease some of the distraction that we were seeing during our didactic period.
And make sure, too, that the clients are getting the most out of the group as well. We want to make sure that they are attending and gaining something. Mm-hmm. Mm-hmm.
Yes. So, and that's a lot of the times we also wanted to look at, like, is there a certain kind of fidget? So, like, if you have just a squish ball that you can just hold in your hand compared to something that you actually have to, like, attend to and manipulate, was there a difference in that? With something that made noises, a lot of the times we noticed that we were having to tell them, hey, you're being way too loud with that fidget. Mm-hmm. I get that it's a pop-it, but you don't have to go. So.
Any other questions?
And also another assumption came from a lot of the kids asked us for fidgets. They were like, hey, do you have this one? Can we have this one? So we wanted to see, like, you guys want them. Is it actually beneficial for you guys? So that was where another assumption came from, was that there's just always a constant, where's the fidget box? Can we have the fidget box? So we actually ran the group for a year before we actually decided to start to conduct and look at this research. So we had about a year's worth of just, like, clinical experience with these kids, knowing that they were just obsessed with fidgets. Some of them would say like, man, I wish I could have one of these. And we were like, just wait till the end of the year party. And those fidgets got bought up so quickly with their points. So it was dependent on the kiddo. I think a lot of them, after the first semester, realized that the more I engage, the more points I get. So the first semester was a little rough with engagement, and then follow up. Yeah, and then also we did have some kids that would ask us what we were tallying, and we were honest with them what we were doing, because we also reminded them that they were earning points. And some of them would like, how many did I earn today? How many do I have total? Can you tell me my totals? So some of them did care and want to like earn as much as they could. Then they're also teenagers, so I know some of them care and they're just acting cool. So not yet. This is some preliminary research. We were just seeing if they created the similar hierarchies. Our next step is to then take it into the actual group setting and do some recording on when they're present versus when they're not. But that's a lot. We got to figure that out with control groups and stuff like that. But no, great question. Thank you guys for your questions. I think that might be our time. So just don't forget to sign out up here or in the back when you guys are heading out. And thank you.